diabetes is a dreaded condition for most young women who are pregnant, and we'll be dealing with those issues in several of our previous videos. But we also get a lot of emails from young women who are type 1 or type 2 diabetes and send us a lot of queries on pregnancy. To deal with those issues, today we have with us Dr. Bella Palnitkar, who is a practicing gynecologist from the suburban Mumbai of Villa Parle. Thank you so much, doctor, for being with us. Let's cut to the chase. First of all, tell us what's the difference between type 1 diabetes, type 2 diabetes and gestational diabetes in relation to pregnancy.
Okay, type 1 diabetes is called an insulin dependent diabetes. It is an early onset diabetes which is diagnosed very early in life. You also call it juvenile diabetes. Whereas type 2 diabetes is a late onset diabetes which can come anytime, say around 20-25 years till late 70-75.
True.
And the third category is gestational diabetes, which is diabetes which is diagnosed after a woman knows that she is pregnant. She comes to our clinic, we diagnose her as that she is pregnant, then we do the tests which are mandatory, which are a screening test, and we realize that she is a diabetic. So that's gestational diabetes.
And usually the gestational diabetes comes during the second trimester?
No, yes, generally during the second trimester, but we can see it during the first trimester also. But generally, patients who are detected in the first trimester are either type 2 generally are type 2 diabetes who have never been diagnosed to be diabetics, and they come to us, they realize that they are pregnant, and then we screen them, and we cannot say whether they are gestational diabetic or they are type 2 diabetics who have not been diagnosed.
Okay. It's actually a dangerous condition then.
Yes.
Okay, doctor, when you are already type 2 diabetes, when you are pregnant, there are two situations. One is that the pregnant lady may not even be aware that she's diabetic already.
Absolutely.
And second is they know and they may be having drugs. So in both situations, let's deal with the first one. If they are not even aware of diabetes, how do you deal with them? What are the complications that they get into?
Okay, the first part of the question, that how do you deal with them? The moment you realize that the screening test, the basic screening test is blood sugar fasting and postprandial, which is done for each and every pregnant patient who walks in your OPD. Whether she comes in the high risk group or whatever, that's it. So once we realize that she's a diabetic, the first thing we do is we counsel her. The second thing is we need to run a few tests to find out how good her glycemic control has been. So there's a test called glycosylated hemoglobin or HbA1c, which is a blood test for which you do not need to be fasting. It can be done right in when she comes for that particular visit. That will show us how good her glycemic control has been. Okay. Now if this HbA1c is about 10, okay, then she comes in an extremely high risk category. Like, what do I mean by high risk category? Her glycemic control has been poor, so the chances of congenital anomalies in her baby are very high. Okay. Some anomalies can be diagnosed in the first trimester. Some anomalies can be diagnosed only in the second trimester at 20 weeks. So it is very difficult for us to tell the patient that she has to wait till 19 weeks for us to do a sonography and then understand that her child is abnormal. So
it's difficult to terminate the pregnancy after that?
Government of India, in our country, the law is up to 20 weeks we can legally terminate the pregnancy. But by the time we do it, we do a first scan, we realize that it is an anomalous baby, then the patient we counsel, then she asks for a second opinion. Sometimes they go a little above 20 weeks, like 20.5 and 20.2. It becomes very difficult and very tricky because it becomes an illegal.
The legal part. What I'm saying is, as a medical problem also, it could be dangerous to terminate pregnancy at that time?
No, you can terminate the pregnancy.
Okay.
See, looking at everywhere, there are risks everywhere, but giving a mother an anomalous baby is not right. So, yes, you can terminate it with some risks.
Okay. And when you talk about, congenital anomalies, what would they be in type 2 pre-existing diabetic pregnant ladies?
Unfortunately, diabetes and congenital anomalies is is a very big issue. Diabetes is one condition which can affect the baby's heart. It can cause different kind of chromosomal anomalies. The most commonest anomaly is seen as neural tube defects. So CNS, the cardiovascular system, and chromosomal anomalies are the most, for the baby, are the most common anomalies seen in diabetic.
Just explain what are these things for us?
Okay, neural tube defects is whenever there is some kind of developmental problem in your central nervous system. Okay, it can be different kinds of defects. The spina bifida is the most commonest defect, where your spine is abnormal and you have a small opening on the baby's back. Okay, there are other defects like cardiac anomalies. So there will be some developmental problem in the baby's heart, and chromosomal anomalies can be different kind of trisomies. But the commonest are the neural tube defects.
No, neural tube defects or any of these spine problems or cardiac or chromosomal. What would be the symptoms in the babies that people should look out for? And second thing is that does it come immediately after birth or it could be in future?
These are developmental defects. That means the baby is born with it. Okay, and sometimes it is very difficult for the baby to survive even for a few minutes or hours after it comes in this world. So these, unfortunately, a few years back were never diagnosed because we didn't have sonography. But now with advanced sonography facilities, at 20 weeks, a good sonologist with a good imaging device can diagnose this. So this problem can be solved by terminating the pregnancy if the patient and the doctor both are vigilant.
And this can be detected, with finality in sonography or any of the tests?
Yes, absolutely. After between 18 to 20 weeks, not before 18 weeks. It's very difficult because the size of the baby is small and obviously it's like a dimple. So it's very difficult. But after 18 weeks, it can be diagnosed very easily.
I see. And is there any kind of tests which are done like a biopsy kind of thing where you take the part,
There is amniotic fluid sampling wherein we put a needle, ultrasound with help of an ultrasound.
Okay.
So that's called as ultrasound guided amniotic fluid sampling, wherein we take a few drops of amniotic fluid through a syringe and that is sent for chromosomal analysis.
And what do you find from that, doctor?
All chromosomal, any kind of chromosome, like these trisomies, not the neural tube defect. Neural tube defect is a structural problem, so you need to visualize it with help of sonography. Chromosomal anomalies are detected by amniotic fluid sampling. So these tests have to go hand in hand. When you diagnose that a patient is a diabetic, you need to do both. In fact, all the tests. This comes as a part of a workup of a diabetic patient.
Doctor, in all these cases, what are the percentages that it would happen? If 100 such patients come to you, or rather 100 pregnant ladies come to you with already type 2 diabetes, what are the percentages that they will have these problems and some might have lucky enough not to have any problems?
Yes, you're right. The basic screening test which I told you was HbA1c. Okay. Now, what the studies say that, or what we have read in books, or what we have experienced in the last 15 years of our practice is that the women who have HbA1c level above 10 have a very high percentage of around 10 to 20% chances of getting these anomalies. Whereas women where the HbA1c is less than 6 very rarely get this chromosomal.
6 would be almost normal.
Yes, but
diabetes is very controlled.
Yes. So the screening test will be done for all the diabetics, but the chances of getting chromosomal anomalies is very high when the sugar is not being controlled. It's as simple as that. Because the sugar was not controlled, the baby was exposed to a very high glucose level during the developmental period or during the organogenesis. That is why the chances of anomalies is high.
That would be the first few weeks of pregnancy?
Yes, first few weeks, which are very critical. First 5 up to 6 weeks.
I see. Doctor, now how different is gestational diabetes and pre-existing type 2 diabetes in pregnant women?
It's quite different because what happens is gestational diabetes may come in the not in the first few weeks of your pregnancy.
Correct.
Okay? So first 5 weeks, when the period of organogenesis is gone very smoothly, then the woman has developed this diabetes.
So the dangers are less.
Yes, as far as the fetus is concerned. Okay, the maternal complications remain the same. Like she may get hypoglycemic attacks, she may get diabetic ketoacidosis, the baby may be very big, she may get a macrosomic baby or but the important part, the most dangerous part is the congenital anomaly. That part goes very smoothly.
And in what situations would you actually recommend termination of pregnancy?
I am a female and I feel no mother should get any anomalous baby, So if you ask me, if I feel that even if there is a chance that they say that there can be a neural tube defect, I feel it's wise terminating. It's not right having an abnormal baby. Why should a mother live with an abnormal baby all through her life? Because with such kind of imaging techniques which are available right now, it's quite simple to detect it, and every woman should see to it that the 20-week scan, which is mandatory, is done in all the patients, especially for these patients, to detect these anomalies.
Doctor, the obvious question there is, what are the actual symptoms in the baby which will come because of these complications? For instance, the nervous problem, spine problem, cardiac problem, or chromosomal problems.
The baby
if
is
it is born,
not
then what happens?
fit to live.
Oh, none of them would survive.
No, a neural tube defect is a big defect in the spinal cord which can affect his ability to pass urine or to pass stool, or it may. So the baby cannot thrive, it cannot live. So these are completely non-compatible with living a normal life.
And will that can it also be a stillbirth already?
Yes.
That
We are stillbirth also.
Doctor, now what are the dangers to the mother when it comes to type 2 diabetes pre-existing?
Starting from the first half of the pregnancy and the second half of the pregnancy. The first half of the pregnancy, the commonest complication we see in our hospital or in our OPD is they come with these hypoglycemic attacks. They are almost collapsed because the sugar levels have gone very down. Patients in the first 3 months do vomit a lot. They get this nausea related to pregnancy. On top of it, they are taking these anti-diabetics, so they come with hypoglycemic attacks. It's the most commonest complication that we see. But the other complication which I need to mention is diabetic ketoacidosis, which can happen in these patients and it can be life-threatening.
That would be just like any other type 1 diabetic who has ketoacidosis.
Yes. So explaining her to monitor her ketones along with her blood sugar is mandatory. So we need to counsel the patient about monitoring her ketones also, which is as equally important as monitoring her blood sugar levels.
Doctor, now when it comes to hypertension coming along with type 2, because that's quite a common combination, it's a deadly combination actually. What kind of complications can happen to pregnant women?
Diabetes and hypertension means it's a bomb for us. Pregnant woman who comes with diabetes and hypertension means doctors consider them as the most high-risk patients. We write everything with red ink on their papers because the most commonest complication with preeclampsia is, the maternal complication is she can throw a convulsion because of very high blood pressure. So we need to monitor her sugars, we need to monitor her ketones, we need to monitor her blood pressure also, and start an antihypertensive.
Mm-hmm.
So this is the most deadly combination. But apart from that, there are fetal complications also. Because of high blood pressure, the baby can get IUGR. The blood flow to the baby is compromised. So it becomes a growth retarded baby. So the baby also needs to be monitored. The growth of the baby has to be monitored every monthly. So that's an additional job for the doctor.
Doctor, what happens if the diabetes is fairly under control? Will the baby have any such problems?
No. The trick is how well a doctor controls the patient's sugar. That's the most important thing. A well-controlled diabetes will cause least possible problems to the mother as well as the baby. Now the role, you cannot admit the patient for 9 months. 9 months is pretty long a time to admit a patient. 9 months means first 1 month after 8 months of monitoring.
Sure.
So the important job of a doctor is to counsel the patient, and home glucose monitoring, that plays a very important role. Not just the patient, even the patient's husband, the partner. Suppose if she's working, her colleagues all need to be aware of that. She's a diabetic, she's pregnant, she can get hypoglycemic attacks, how to manage that, and most important, counseling of the patient.
You know, one of the most common questions from caretakers in terms of pregnant women, from the husbands or partners, is what is the way, what are the things that they can do to prevent problems? So I guess this is one of the important things, how to take care of a pregnant woman, right?
A is her diet, B is her control of her blood glucose, which is either with an oral hypoglycemic agent or with insulin. That's B, and C is psychological part. So they need to be very supportive. It's going to be a difficult, yes, basically about support. So it's going to be a very difficult pregnancy, which we need to tell the patient as well as her relative and the in-laws, everybody at home. It's not going to be simple. She has to prick herself 3 times in a day. She has to monitor her own sugar. Plus the intense monitoring for the baby, also the repeated sonographies, all that is an additional. The number of visits do increase to the doctor, which is obviously nothing very pleasant to sit in the doctor's chamber or to wait in the waiting room for hours together.
But do you see any kind of compliance issues among your patients? You do?
Yes. Unfortunately, in the country, pregnancy is supposed to be something like it just happened, and why do you need a doctor? You know, that's what the mother-in-law says. I never went to a doctor, I just went once. So for her, a doctor patient or her daughter-in-law visiting a doctor twice or thrice in a month may not be liked by her. So compliance issue is going to be there. Now if you're dealing with a higher and the educated class, yes, there's not too much of a problem. But as you go into the lower classes, where they do not really like, they say that we have 3 daughter-in-laws and other 3 never went to a doctor, or they just went once in a month, or say once in 2 months. Why does she need to go every 8 days or every 15 days?
Okay, doctor, is there any kind of neurological or psychological problems that the children will face because the mother had type 2 diabetes pre-existing during pregnancy?
No. Like other than the CNS developmental defect, there's nothing much. If at all, it has to be, the way I told you, it has to be a neural tube defect, which has to be a developmental problem. But we have not seen the IQ being affected. So either it's something that's a big disaster, or it's never that the central nervous system is affected in the way that the baby will be a low IQ baby.
So it won't by any chance lead to autism or any such problems, is it?
At least it's
because
not
we have got
been
mails asking us, children with autism, is it because of diabetes in mother?
There is no data which says that.
Or from your practice also you're not seeing?
No, we have not seen.